Welcome to the Ortho Joe Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Mark Swinkowski from the Journal of Bone and Joint Surgery.
Well, good morning, Mo. Happy summer to you.
Happy summer.
Got to have your cup of Joe.
Absolutely.
I know you've been away, you've been traveling a lot, and I really enjoy reading your posts on LinkedIn, and I would commend that line of prose and artistic work to any listener because it's you've really, I think, given us in orthopedics a major contribution in the whole issue of balance in life and professional and family and the different sides of our brain, et cetera. So I commend you. Keep it up. It's great work. I enjoy reading it. And I know you were in India. So I know you've been traveling. Yeah. And Christina gave us a couple weeks off from Ortho Joe. So yeah, I'm a little bit sleepy. So I absolutely had to have my cup of Joe this morning. But so this is one of our episodes where we just talk about what we have been publishing recently and what's on our mind, what caught our interest, and what we want to chat about. So I'm going to give you the chance to go first. What's been on your mind from OE?
Yeah, sure. So let me just preface it by saying that the thing I always say, I haven't been to India for a couple of years now, Mark, and I know you've traveled there a bit. Yep. India for me is always a race. And those who have traveled to India understand exactly what that gastrointestinal race may be. And so the goal is to get out unscathed. And I've tried multiple concoctions to stay healthy. And I am healthy, but I will say that India always wins. Period. That's it. India always wins.
This is fascinating to me, Mo, because I have to tell you. So you're talking to somebody of English or English and European Polish background. Yeah. I never have trouble with Indian cuisine, and I've been there probably 6 or 8 times. It just doesn't bother me.
So that's amazing because so the thing is, I eat anything and everything, and the problem is when I go there, I have my rules. Okay, just take care of water, avoid places you haven't, just off the street. Yeah. I walk in and first thing, I grab a glass of water from a small little place and I have the first street food I have. I think I'll be
that's the difference.
Right? I'll be fine. So it's just everything, the sights, the smells, the tastes, everything of India is so amazing.
Overwhelming.
Overwhelming, right? But India wins. India always wins. Okay. So I've been thinking about what I could speak to, and I thought there would be one area of interest that has a methodological bent on it. And this gets back to a paper that we both had a podcast on and also did a review on. It was a Lancet paper in April of 2022, so not that long ago. It was a UK trial. And let me just give you a bit of a précis to what I'm talking about. I'll get into the trial very quickly and get your insight. So this is about an in-space device. This is a subacromial balloon spacer for irreparable rotator cuff tears. And it received CE marketing in 2010 and had been used in about 29,000 procedures until July of 2021 when it received FDA clearance in the USA. The National Institute of Health and Care Excellence, NICE, reviewed the available data for the in-space device back in May of 2016 and found at that time one published case series and a few conference abstracts. So they had said at that point, listen, we think it should be used in the UK primarily for research, and we really encourage a randomized trial. So the authors, this is Dr. Metcalf and the STAR Reacts team, went ahead with a trial of about 117 participants who were randomized. They called this a randomized double-blind multi-center trial. This was an adaptive trial. We can talk about that too, but principally, they went out to try to solve this issue. And they said, what we'll do is we will look at this in patients who have arthroscopic debridement for subacromial of the subacromial space with a biceps tenotomy. So in other words, that's the debridement only group. And then did the exact same procedure adding the in-space balloon spacer. So that was the comparative group. Ultimately, they followed patients for about 12 months. And they used the Oxford shoulder score at the 12 months as well. Here's the point I want to make. Participants and assessors were masked, Mark, in both group assignments. So masking was achieved by using identical incisions for both the procedures, blinding of the operation note, which is, I think, was an important factor, and consistent rehab program. So they're really trying to make sure that anyone involved in the outcome assessment at any level did not understand or was not aware of the actual treatment. So what they found was, in these 170 patients followed, that debridement only led to a significantly greater benefit than the actual active group with the spacer. Now,
Yeah.
conversely, at the same time, I'll just put this little note here, same month, there was another trial published on the exact same thing. This was published by Dr. Verma and colleagues, and this was in the Journal of Bone and Joint Surgery, another very good randomized trial.
Yeah.
About 184 patients, on the rough same size, the number of patients. And basically, this was coded as a single blinded study. So just to clear, same general patient population, we can argue the details, but principally the same general treatment population, the same plan, 24-month follow-up and using the American Shoulder and Elbow Society score. They did state up front, the authors, to their, they were transparent. They said, one of the limitations is that the evaluators of physical examination were not blinded to treatment group. And they said, which may have led to a potential bias, but that was in the discussion itself. They found actually that there was no difference. And in fact, that the in-space arm led to better outcomes.
Right.
We can get into the details of the nuances, and I'm not here to debate, the details of the specific procedures, but in the context of blinding, it was interesting to me, right? We've often talked about some of the greatest threats to introducing bias are, lack of concealed randomization and blinding are the two. In fact, the Haddad scale, JADAD, way back when, use those as the two primary factors. And on ortho evidence, people always get angry with us when they perceive they've blinded, we downscore the trial, saying, no, it's not truly blinded.
Right.
This is a type of trial that has some interest in that. And I wonder from your perspective, I said a lot here, but I wonder from your perspective, do you believe that that could have been a factor in why these trials had different outcomes? And again, we're not debating which one's right or which one's wrong, more so the difference in outcomes.
Yeah, so when we had a brief email exchange about what we thought we might talk about, I, of course, went to our website and looked up what we'd published on this and came across this trial. And the very first thing I thought of, since it comes up when I am giving presentations on how to optimize your chances to get manuscripts published, was the issue of blinding.
Yeah.
And really, I don't follow why the investigators didn't have blinded assessors of outcomes, because it's, as you and I know, it's not really that difficult to do. You have a
Correct.
physiotherapist or another colleague who's not involved, and if you have different incisions, you just put a garment on.
Yeah.
And you have blinded assessment. It's really the simplest thing to do to enhance the believability, if you will, of results. And yes, so the answer is a strong yes, that I think that this may have played a major role. It's, you obviously have enthusiasts for the procedure who are performing the procedures, otherwise they wouldn't participate in the trial. So,
sure.
And it's just human nature that we want things to be better, even though it's, I'm sure, at the subconscious level.
Oh yeah, and I remember David Sackett, the late David Sackett, who had said that one thing that he had tried in some of his trials post, like just before the trial results were revealed, but he had gone back to patients and said, to really see if blinding was truly occurring, asked patients, what do you think you had? Did you think you were in the treatment group or the control group? And it was an interesting way to understand whether blinding or masking in this case had been successful. Now, he later sort of said, he didn't think that made sense because, people who generally feel better just think they're in the treatment group. And the thing is, if your treatment actually works, then they're more likely to guess right. So that became some of the challenge, but it was an interesting dynamic. And I wonder just how many patients would have had the perception of knowing that they had the treatment, right? It's easy, like, when we document something, it's one thing, but to actually have a sense of whether patients are truly blinded, my perception is the more people who don't know, the less likely it trickles back to the patient. And that's all. And so my perception is, I think it is a real difference. I do think that, blinding one more group of individuals, especially when you're looking at functional outcomes that are likely going to have some third-party assessment, that individual knowing or understanding it, there's going to be an implied or implicit
Yeah.
bias in how we assess it. Some people may believe, and the argument would be, well, it's always going to be in favor of the device. Not necessarily. There may be many reviewers who think, I don't think it works.
Yeah.
So it can go both ways. The problem is we don't know which direction it's going to go. And we typically make the judgment that, oh, if you haven't blinded, there's going to be differences. And so this was just a kind of, I would say, somewhat of an interesting finding that I wanted to share with you.
Yeah.
And I'm not sure what the next thing to do. So when you think about this and you see another papers come out on the topic, two discrepant papers, what do we do here? Because what's the guidance at this point? Because if you look at the UK guidance, UK guidance is going to be very different from what's happening probably in America, I would imagine. Because
yeah, absolutely. Well, I think, we're big, strong believers in the quality of the evidence. And I think we have to give the nod to the UK trial as being a stronger experimental construct. And
the thing I would say is, right now, so if we were to go ahead and do a meta-analysis, I say, okay, you have two trials, let's compare them, put them together. It's not going to be necessarily that meaningful because you've got two different methodologies and you put them together and you're probably going to get a null.
Neutralize each other.
Yeah, but it's not really null, right? There's something going on here. So there'll be a lot of heterogeneity there. Sadly, I'm not sure we've answered the question in a way, at least in North America, there's going to have to be some additional, evaluation. Now, I know for a fact that we may get some listeners thinking, okay, these guys have it wrong. They don't know the nuances. The Lancet trial had a whole bunch of errors. The Lancet folks, I'm sure, are thinking, following, and this is where we get into the back and forth debate.
Yeah.
But at the end of the day, we don't have to have debate if we have a big trial, lots of centers, and we do everything we can to try to keep it as robust as possible. Anyways, that was my 2 cents this morning.
Yeah. Well, it just goes back to the essential difference of surgical trials versus pharmacologic trials or medical trials, that you just can't, we don't do placebo blinding very often. That's way too difficult. And I recall very early in your career when you were just getting started in your trial career and attracting your mentor, Gordon Guyot, into the field of surgical trials, because he knew, rightfully so, that surgical trials were way more difficult. And he was, in essence, deciding to play from the back tees in golf.
Absolutely. And the funny thing is that the FDA, not even funny, FDA, their biggest concern with surgical trials has been surgeons aren't blinded. So when you're making radiographic assessments on anything, whether it's loosening or implant or healing, whatever the case may be, the reviewers absolutely know what, for the most part, that there's an implant. They know that they're unblinded. So there's a huge bias. And that leads to a lot of debate at these kind of meetings. And quite frankly, I should think, oh, this is much ado about nothing. But actually it isn't. It's a real serious concern that we have. And I think anything we can do, as you said, to add one more safeguard is always better. And it's worth every penny that we do, because then you don't have the debates afterwards, I guess.
Yeah. Lessons we learn over and over again.
Yeah.
Well, so I chose from the most recent issue of the journal, the lead article, which is on tranexamic acid in high-risk patients with hip fractures. Now, you and I have spent decades studying hip fracture patients, and this comes out of the Mayo Clinic. It is not a randomized trial. It's a level 4 evidence, but it does make an important point. They studied in 4 hospitals over a 4-year period of time the use of tranexamic acid versus no TXA, and they included in this group patients who are very, very high risk with diabetes, dementia, et cetera, all known to increase morbidity and mortality. And with some sophisticated statistics that were, of course, approved by one of our deputy editors for statistics and methodology, they basically showed that in the high-risk patients, there was no increased risk of mortality, DVT, pulmonary embolus, MI, or stroke within 90 days of surgery. And I just felt that this was really important information for clinicians, even though it is level 4 evidence. It would be prudent for us as an orthopedic community to do a blinded RCT on this, which would be difficult, as all surgical trials are. But I think this is important information. And I know that, you have published a fair amount on tranexamic acid in other applications. And was just wondering what you thought about this particular study, as well as what you've learned in other applications such as knee arthroplasty, et cetera.
Absolutely. So, and I went back the same way, and I looked back, and then in May of this year, so it's fairly recent actually, we put out what we call the OE Originals mark, which is sort of our own internal evaluation of the evidence. And to your point, surprisingly, there's trials. There's several trials. Now, the issue is going to be, to your point, the word large. We need potentially. We always say that we need a bit more data, but we have some insights we can share. The one thing that really came up about tranexamic acid, right, was its real use and evidence in other areas. So when we look at where it's really had a huge impact, it's had a huge impact in cardiac surgery and C-section. It's had a huge impact in joint arthroplasty. But the question was, hip fractures, is it the same or different? The POISE-3 trial, this is a trial led by Dr. PJ Devereaux. He's a McMaster University colleague, but has run numerous large trials. This was 9,000 patients, and this was all non-cardiac patients, including hip fractures. And really, they basically found that this was placebo-controlled, and they identified that there was a significantly lower incidence of what they called composite bleeding outcomes. Now, that covers the whole gamut, but it gave a broad sense that probably, hip fractures would fit into that area. Now, there's been lots of other subspecialized focus on hip fractures. And to your point, great observational data, such as, what's coming out of the Mayo Clinic, and also some supportive trials as well. We identified in this review very briefly about 9 randomized trials, roughly, just under a couple of thousand patients or so. I think it was like 879, maybe 1,000 patients, 879 patients or so cumulative. So you can see 9,000 patient, big RCT on everything, but the hip fracture data set was a little smaller. So that's why I think the observational data being added to this gives us just more information, which is, I think, very important. Same sorts of things. I mean, real compelling storyline, as you suggested, on reducing bleeding risk and bleeding outcomes. Still really unclear about the major, so no difference in major safety events like mortality risk. The problem is, do we actually have enough information to make that? Probably not. But all the signals at this point would suggest that it's quite safe to use in patients with hip fractures, similar safety as we've seen in other areas and other, indications. And really seems to be pretty significant. And I'll get to the specific, but we talk about total blood loss seems to do significantly better in reducing that. And then just the need for transfusion seems to be significantly lower. But the other outcomes that are, there's a whole bunch of other outcomes related to, events, vascular events. It's no difference, but again, we don't know if we're powered for those kind of differences. So overall, I think we're all saying the same thing.
Yeah, but the trend as we use that word is towards favorable use of this.
Absolutely, yeah. I mean, without any real safety signal risk and better outcomes on some of the composites like bleeding, it seems that it would be a reasonable standard for adoption. Until there are larger trials that should come out, and I think we're continuing. It's not like the perception is it's been answered. It's just that we're getting more information with every publication.
Yeah, this also caused me to reflect on how our field of orthopedic surgery has progressed in terms of blood management, particularly over the last 25 years. And all of the things that we were doing, having patients bank blood and transfusing people with hemoglobin of 10 and above, and all of the progress we've made, including tranexamic acid, has really moved the field forward to the point really where we don't really talk that much anymore about transfusion requirements, et cetera, due to the advances we've had in understanding and in pharmacologic intervention. It's really been a good story for us in orthopedics.
Absolutely, Mark. And if you look at where we're headed, you remember the hip attack trial, the first one that came out in the Lancet not that long ago, that suggested that, earlier treatment, rapid acceleration of hip fracture care, meaning oftentimes patients, we don't have the luxury and the time to do what we used to do 10 years ago. If you're looking at accelerating patient care, you've got to come up with ways in which, and treatments and allocations that you can, get patients through the system very quickly and safely. The hip attack 2 trial will be looking specifically at accelerated care in these patients, that'll some of which and many of which will be on, tranexamic acid, as a thinner, right? So they're going to be on something. It'll be interesting to see how these sorts of trials, find their way, because I think we're getting into this true care path that is leading, as I've said this how many times, every time the word hip fracture comes up, some of the greatest innovations around hip fractures are unlikely going to be implant-based and likely care-based, care path-based. And I think that's where we're heading.
Yeah. Yeah. Not going to be new devices. That's
Doesn't seem that way. Yeah,
we've run that course. So, well, it's been great to chat with you, Mo. And I think these episodes where we just talk about things that we perceive as being important in our respective journals are important to share with the audience, and just confirms to me as the editor, and I know to you, that all of this is probably worth all the work to get these things out to the people making clinical care decisions. So cheers to OE and cheers to JBJS. And I hope you have a safe summer, particularly with that interest of yours of going 60 miles an hour down a mountain on a mountain bike, which concerns me a little bit. Doesn't disc golf, frisbee golf doesn't worry me so much as that activity, but
but you know what disc golf? But you know what this disc golf has done? It's given me immediate epicondylitis, and I've never had that from riding downhill. Right? I might have, because I have a helmet on, so I'm good. I'm good.
Okay.
Crazy. Anyways,
have a good day.
All right. You have a great day.
Cheers.
Take care.
Bye.